let's start with this case. This case was very important to us because this is the case where we started our OLIF journey. So let me give you our first case of OLIF. So this 55-year male had a laminectomy of L4-5 done 15 years back and presented with back pain for 2 years, neurological claudication, and he was in significant pain, so much so that he was even had difficulty in walking. And as you can see from the X-ray, there is the lower level has fused. There is a laminectomy from the previous surgery, and there is a definitive focal kyphosis. Along with that, the MRI says that there is a significant stenosis as well. So this was the case where we had a challenge of revision surgery. We needed to do a revision decompression. Even we had to restore the coronal and sagittal balance. So something like the type 2 scenario. And we did have our options of either choosing PLIF, a TLIF, XLIF, the OLIF, and the ALIF. Considering that I did have some training with OLIF, but this case I thought is the ideal suited for OLIF, and this is where we started our OLIF journey back in 2018. And because it was a L3-4, bit easy to start, I think we needed to do a better job than just a simple TLIF. So we went ahead with the OLIF, and this is what we did. As this is the exact picture for our first case. I used to do neuromonitoring in those days. We don't do it anymore for OLIF, but when we started, we used to rely on neuromonitoring. So this is the position we all know we take, a right lateral position, and this is the draping of the patient. And as we know, the approach of OLIF, you go almost 2 to 3 centimeter anterior to the anterior part of the body. You go through the abdominal muscles, the external oblique, internal oblique, transverse abdominis. You retract the peritoneum, you find the psoas, you retract the psoas, and you go in a natural corridor. So this is a natural corridor between the psoas and the abdominal aorta. And this is how you dock your tube and do your job. And this is from this case, the intraoperative images. And again, then you flip the patient and then you do your percutaneous fixation. So that is the basic of oblique lumbar approach. And this is what we could achieve from this case. A single level OLIF, we could do the indirect decompression. We could restore the balance, both the sagittal and the coronal imbalance. And see, this is his previous scar. This is what we have given him. And now we have a 3-year follow-up, and he has absolutely did very well. So this was our starting of the journey. And as we went, we had few more interesting cases. So this was a 60-year female. She had a previous laminectomy and now landed up with adjacent segment disease. You can see there are instrumentation. You can do a posterior revision surgery, but you need to remove everything, all the implants, and go in and again redo everything. So what we thought is we chose the OLIF, and she was in terrible pain because of instability. I just moved the audio, and as you can see, with each step she's wincing with pain, and that is the amount of pain she had. And we chose to do a OLIF, and we went and we could really bypass the whole corridor and go through a lateral oblique approach, and 1 to 1.5 hour surgery with a 20 ml blood loss. And what we did is we used the cage with the plate here because we didn't want to really go and do the posterior job, and we thought it's adjacent segment, it's not a very unstable scenario. And this is the beauty of doing a OLIF, because you go through a natural corridor. Once you take out your retractor system, the muscle simply falls back, and that is what I like the most about the whole surgery. So, and this is what we could achieve. Again, almost we have a 2-year follow-up with her. In spite of doing a single cage, I don't do it routinely, but something like this, I still manage it with a cage and a Wiroc plate. And this is her previous surgery, and this is the only scar we gave her. And she is immediately post-op day or 1 or 2. And you see, it did make her very, very comfortable with a single level surgery that we did for her. And then we have gone and done few more cases. This was again a revision scenario. You can see the previous laminectomy, and again we went for a OLIF. And now for last 1.5 years, we have been doing it for even up to 2 level in a single lateral position. So we put the cage from the front and we could pass the percutaneous screw from the back. And see, this is the beauty. You see, I know you can do it many ways, but we did it. We went for a OLIF. Look at the indirect decompression. Actually, this is not the indirect decompression. The whole thing has just collapsed, and the annulus is just bulging. The moment we have put the cage, it has just gone back to its original position. And she just came recently, 9 months follow up, and see that there's a looks like a decent fusion, and she has done wonders. We have her recovery charting with us, and she did absolutely fine. And since then, as we went for, we have started doing the type 4, what they described. This was a previous laminectomy done some 5 years back and presented with degenerative scoliosis. And so we went for 3-level OLIF, and this is what we could do. She had some cervical as well, so first cervical and then the lumbar. But what is very, very interesting, if you see, not only that lumbar profile, the whole profile of the patient changes. And that is where what they were talking in the paper, that type 4 surgery, you can really restore the sagittal and the corneal imbalance. So she had a PILL mismatch of 38.2, and we could almost redo it again. We have almost, I think, 6 or 7 months of follow-up, and she has really done well. So how do I look at OLIF? It's not that I do OLIF for all my cases. Frankly speaking, less than 5% of my revision is OLIF. But when I feel I have to get more out of a level, that is where I use OLIF. And MIS in revision has been very interesting, and we really prefer if we could choose a MIS procedure over a open. And this is just published, not even just accepted, not even published. This series is for more than 400 cases, from where we compared open versus MIS, and we looked at various parameters. And if you look at the dural tear, in our experience, we had a dural tear as high as 40%. Maybe we were not that great in open surgery. But when we compared the dural tears in our same hand with our own institute and with the MIS, and it doesn't include only OLIF, it has, like most of them were tubulars and MIS TLIF. It was as low as 13%. So MIS does change and does reduce the chances of complications. And again, we looked at the return to work, and the return to work in MIS was significantly early. So I really believe that minimally invasive option is a very good option when it comes to revision. It doesn't mean I do all my surgery OLIF instrument, all my cases. We do use tubulars, retractors, and we do revision surgery using tubes or even endoscopes. So that is where I will conclude that I believe MIS has advantage revision surgery. You can choose any of these techniques which you feel works best for you. But as the paper said, when it comes to restoring the lordosis, or if there's a sagittal imbalance and you want to use fusion, I think OLIF and ALIF will do the trick for you. Thank you so much.